Hello, welcome to my YouTube channel. Today we're going to talk about a very high yield topic which is frequently tested on the board exams. And I'll give you some solid information how to tackle a USMLE style question and how to augment your score in the optimal way. So let's get started. This is a 67 years old who is brought to the emergency department by his wife 30 minutes after a 15-minute episode of inability to speak. So this is a very high yield phrase, very high yield information. The duration of the episode was just 15 minutes, and the patient had aphasia, which is inability to speak, and the patient is having a risk factor hypertension. And 3 weeks ago, the patient had a transmural myocardial infarction, and the patient had a coronary artery angioplasty and stenting. So, and patient is also on some antiplatelet drugs such as clopidogrel and ACE inhibitor. This one is ACE inhibitor, benazepril, and 81 milligram aspirin. So patient is already on antiplatelet drugs and ACE inhibitors, and patient is having a very heavy smoking history, which is around 60 pack years. And on arrival, patient is well oriented, and patient is not having any hemodynamic instability, and patient is not having any focal neurological finding. And carotid duplex ultrasonography shows 40% stenosis of the left carotid artery. So this is important. It might be a tangential point, but I'm going to explain it because it is really high yield and it is frequently tested on the board exam, and it is particularly high yield for USMLE Step 2 CK. So if carotid duplex ultrasonography shows a stenosis up to 80% or less than 80%, so and there is no symptom, so you are not going to perform an arterectomy of the carotid arteries. If the arteries are stenosed less than 80%, right? Less than 80%, and there is no symptom, then you are not going to perform an arterectomy of the carotid artery. And but if patient is having symptoms and the carotid artery is stenosed up to 70%, right? So now that we have lowered the threshold, and we have lowered the threshold up to 70%. So if the stenosis is up to 70%, you have to perform the endarterectomy, because at this stage, patient in this scenario, patient is having symptoms. So if patient is having symptoms and the carotid artery is stenosed up to 70%, you have to perform endarterectomy. So this is the indication for carotid endarterectomy. So you have to remember it for USMLE Step 2 CK. This is not for Step 1, but it is important for USMLE Step 2 CK and for Step 3 purposes. So the question is asking which of the following is the most likely diagnosis. So option A is embolus from a ventricular aneurysm. Option B is infarct of the lacunar artery. Option C is intraparenchymal cerebral hemorrhage. Option D is spasm of the cerebral artery. And option E is subarachnoid hemorrhage. So in this case, the correct answer is embolus from the left ventricular aneurysm. So why is this the right answer and others are wrong? So I'm going to give you a hint about it. So first of all, the most important clue or hint or phrase in this question is the history of MI, recent MI, and patient had a stent in the left antidescending coronary artery, which is basically the major supply for your left ventricle, the ventricular myocardium. And patient is also having multiple risk factors. Patient is old age, patient is having uncontrolled hypertension, patient is a smoker, and this blood pressure is also high, current blood pressure. And so all these features are suggestive for high risk of atherosclerosis and high risk of atherosclerosis related comorbidities. So first of all, we have to diagnose what is the condition this patient is having. This patient had a transient ischemic attack, which is uh, 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 abbreviated as TIA. So TIA is basically any focal neurological sign which improves over time, and this time limit is less than 24 hours, right? Less than a day, and the condition improve. Neurological signs or focal neurological deficit, it improves, it goes away. Then you label the patient as transient ischemic attack, right? The patient is having transient ischemic attack. But if the condition doesn't improve, then you label it as stroke, right? So in this case, the patient is having just uh, a, a neurological sign or a neurological deficit which lasted just for 15 minutes, right? So usually it is for 15 minutes, but for conventional purpose, we say that up to 24 hours. So usually the TIA improves within 15 minutes. So now we have to think about the most common etiology for this TIA in this patient. So embolus from the ventricular aneurysm. So you have to remember that after myocardial infarction, your myocardium, it just slows down because of the poor blood supply, because of the fibrosis, because of the injury. It just slows down, it just dilates, and there is an outpouching of the myocardium. So this is known as the or dilatation of the ventricular myocardium. And when the ventricles of the heart gets dilated, so blood have a tendency to pool there, right? And there is an appendage, left ventricular appendage, so blood can basically stay there, and when there is stasis, blood can clot, right? There is stasis, there is turbulence, and this stasis and this turbulence can give rise to embolus formation, and this embolus can dislodge to systemic circulation, to cerebral circulation, to any part of the body, right? So in this case, the patient had an embolus to the cerebral arteries, leading to development of aphasia. Infarct of the lacunar artery, this is a wrong answer, because infarct of the lacunar arteries are the smaller arteries supplying the capsuloganglionic region of the brain, such as pons and like the basal ganglia, thalamus, these regions. So if there is infarct of the lacunar artery, these lacunar artery infarct are going to cause contralateral hemiparesis or hemiplegia, right? And it is going to result in stroke rather than transient ischemic attack. So this is a very unlikely diagnosis or etiology in this case. And furthermore, infarct of the lacunar artery is because of the lipohyalinosis, of the lacunar arteries, not because of the emboli, right? And intraparenchymal cerebral hemorrhage. Again, intraparenchymal cerebral hemorrhage is going to be a very life-threatening, a very dangerous condition, and it is not going to reverse within just 15 minutes. And it is going to, for example, if there is hemorrhage within the brain parenchyma, so it is going to put pressure on the brain. It is going to result in cerebral edema. It is going to cause some focal neurological findings such as contralateral hemiplegia, hemiparesis, loss of consciousness, and it is not going to reverse. Rather, the patient is just going to have altered mental status, rather than, as this patient is having a very alert and fully oriented state of mind. So this is not the likely diagnosis here. Spasm of the cerebral artery and subarachnoid hemorrhage. Subarachnoid hemorrhage is going to present uh, with a very severe headache, very terrible headache, like the board exam represent or give you a buzzword, worst headache of my life, and there must be present some neck pain and like some signs of meningism, right? So, and the patient would not be having any focal neurological sign, just subarachnoid hemorrhage. The patient would not be having, patient would be conscious, and patient would not be having any kind of uh, focal neurological deficit. This patient is having a focal neurological deficit which improved within 15 minutes. So subarachnoid hemorrhage is going to present with headache and with neck pain and with sign of meningism, and there would be no focal neurological deficit in contrast to this clinical vignette. And after some time, like within 1 to 3 days, there is a likelihood of spasm of the cerebral artery. So this is the reason you give nimodipine in these patients. Nimodipine is a calcium channel blocker to avoid the spasm of the cerebral artery, to prevent the spasm of the cerebral artery. So during the first 72 hours or during the first 3 days, there is an increased chance of spasm of the cerebral artery, and this spasm can lead to uh, focal neurological findings, right? But subarachnoid hemorrhage itself is not going to present with the focal neurological signs in the patient. But the stroke or spasm of the cerebral artery because of the subarachnoid hemorrhage, it can present with focal neurological signs. I hope it makes sense. So there is another tangential point that after subarachnoid hemorrhage, the next 72 hours are very crucial for prevention of spasm of the cerebral artery, and you have to give nimodipine. So this is a really high yield point. What is the risk factor? What is the pathogenesis? And what is the treatment, right? So the risk factor is subarachnoid hemorrhage, and the pathogenesis spasm of the cerebral artery, and the treatment is nimodipine, which is a calcium channel blocker. And after 3 days, the timeline between 3 to 10 days, there is an increased risk of rebleed, right? So initially there was a bleed, which was subarachnoid hemorrhage, and then there was a spasm of the cerebral artery in the next 72 hours or 3 days. And then after those 72 hours, there is an increased risk of rebleed, right? So you have to be very careful for control the blood pressure and to highly regulate the blood pressure in these patients. I hope you enjoyed this video. Please give this video a like, share with your friends, and subscribe to our YouTube channel. Thank you so much.